We are dealing with small babies every day, and the problem there is, the big question there is, do we deliver or do we wait? Right? So is this just a small baby or is this a FGR? If it's FGR, then obviously you want to deliver. If it's a small baby, then you want to continue. So that is a very, very complex issue. Hopefully, with this talk, some of those issues will be made more clear. Before we start, let's do a thought experiment. So these are 3 fetuses. There's the blue circle, there's the red triangle, and there's the orange diamond. Now tell me what you think is happening. Sorry. कैसे चलता है यार? इसका और इसका नहीं और इसका मार्कर कहाँ है? Okay. So can you see this? All right. Doesn't matter. Yeah. Okay. So what is happening with the blue circle? Is it normal? Is it large for age? Small for age? FGR? What is happening? Okay, we'll come back to it. What do you think is happening with the red triangles? This should be easy. Is it normal? Is it FGR? Is it small for age? It's IUGR. Okay. And what is happening with the orange diamonds? Is it normal? Is it FGR? Is it SGA? This is also IUGR. And so let's go back to the red, the blue circles. Is it normal? Is it FGR? Is it something else? Not clear. Okay. By the end of this lecture, all of these will become clear, I hope. Okay. The problem with small babies is that most of your cases of FGR tend to be small babies. And many of your small babies tend to be FGR. And smallness has a direct association with perinatal morbidity, perinatal mortality, and issues that haunt the baby even postnatally. So these can have complications like they do not as well in school, they can become obese, they can have endocrine problems, metabolic syndromes, all of those things. So you want to make sure that you're not letting an FGR baby for too long. And as you can see here, smallness has a direct relationship or a very strong relationship with bad perinatal outcomes. So if you have your babies that are between the 50th centile and the 97th centile, you have the best outcomes. But as the centiles start to become smaller, as the baby starts to become smaller, your perinatal outcomes starts to become worse. All right? So that is the importance of being able to diagnose your small babies accurately. Now, how small is small? That is a question, bro. When do you call a small baby a small baby? Any answers? Please? Anybody? Weeks, 4 weeks. So is it 4 weeks at 20 weeks, or is it 4 weeks at 36 weeks, or is it 4 weeks at 40 weeks? After 26, if it is 4 weeks, okay. All right, so that is a big jump. But let us make it more nuanced and more sophisticated than that. Okay? So arbitrarily, smallness is described as a fetal weight or an abdominal circumference of less than the 10th percentile. Some people describe it as a fetal weight or abdominal circumference of less than 3rd percentile. When you do your ultrasounds and you look at the report page, you will see that your reports are given out in percentiles. But when you plot these, in most of the cases, your plots are in standard deviations. So do you know the relationship between percentile and standard deviation? Do you know what percentile means? Okay, we'll do that. Okay, percentile is if you take a population, any attribute, height, weight, any continuous attribute, and you arrange that population in descending order. In ascending order. In ascending order. A percentile represents the point below which you have that percentage of population. So if it's 10th percentile, it means in a normal population, 10% of those individuals will be smaller than that. It will still be a normal population, but most of the people will be above that. If it's 90th percentile, it means 90% of the population will be below that, which means you're looking at a bigger individual or a larger attribute or something like that. Percentile and standard deviations are related. So when we talk about 10th percentile, we are actually looking at 1.28 standard deviations. Not an important number to remember. But when we look at 2 standard deviations, we are looking at 3rd percentile. So when your figures, when your numbers are at the 2nd standard deviation, you know, the line at the bottom that you all are very aware of, it means that that particular attribute is at the 3rd percentile, and you really need to start taking that seriously. Now the problem with 10th percentile or the 3rd percentile is that there is a huge overlap. So what happens is that if you take 3rd percentile as your cutoff to distinguish normal from abnormal, you will get all of the abnormals, but then you're leaving a huge number of abnormals that you're labeling as normal. So the FGR is this orange area and normal is this gray area. If you take 10th percentile, you're getting many of your abnormals, but you're also labeling a lot of your normals as abnormals. You don't want to do that. It gets even worse. Even if you go beyond the 10th percentile, you still have a significant number of babies that are FGR. That's not very intuitive, is it? That you have a baby that is in the 50th, 60th percentile, but it's still FGR. So that is a special class of FGRs that we are going to discuss later in this talk. So if you take any population of small babies, about 40% of them will be FGRs, as expected, as you want them to be. But an equal number of babies will be SGA. They're just small. They're determined to be small. They're just short height. Some people are short height, some people are taller. So these are just short babies that are otherwise normal. And 20% of babies, they're not deprived of nutrition, they're not starving babies. And another 20% of babies are very ill. They either have a chromosomal problem or they have an infection. And these are what you get as early FGRs at about 20 weeks or even earlier than that. So we have just discussed that simply taking one measurement of fetal size is not going to be very useful for you to enable you to diagnose or to distinguish FGR from small babies. Okay, so what do you want to do? You want to look at growth velocities. Okay, and how do you, and we'll discuss how to take a growth velocity. And you want to take a Doppler. And in a Doppler, you have a huge menu of things that you want to put on your table and you want to analyze and then use all of those data that you get to make your decision. And in the future, you might get biochemical markers. They're already in the market, but they're being studied as to their usefulness in the diagnosis of FGR. Smallness. When you say a baby is small, Madam said that 4 weeks. It implies that you actually know what the size should be. ठीक है ना? The baby should be 30 weeks, but the baby is 26 weeks. That is a primary prerequisite requirement. Okay? So that means you need to know the age of the baby. And how will you do that? LMP. You do that with an LMP, or you do that with an early scan at 11 to 14 weeks. Or if it's an ART, you know the date of conception. That is perhaps the most important. Okay, when you're talking of LMP, you must remember that not every woman who claims to have a normal LMP has a normal LMP. About 65% of women will have a period that is about 25 to 30 days, which is called normal. Many normal women will have their periods that are longer than that, and many normal women will have their periods that are shorter than that. So just a question, when was your LMP, does not satisfy the conditions. You need to ask, when was your LMP? You need to ask if she has irregular cycles, and you need to ask about the duration of the cycles. Okay, so you need to have this three information with you before you can make any assessment of the age of the patient. Better than an LMP is an 11 to 14 week scan. And I'm sure Dr. Fazil will be talking about it directly after tea, and I'm looking forward to hearing that talk. And I'm sure he's going to tell you how to actually do a 11 to 14 week scan. It is not as simple as it sounds. It's perhaps more difficult than doing a second trimester scan, and you need to satisfy a lot of conditions to get that. Now, it is very important. Once you have assigned a date, by any means, you are not allowed to change it. Okay, you cannot say, आज देखा तो 26 October उसकी expected delivery है, and then when you see next, no, let me change that. It's not 26 October, it is 10th November. You can't do that. Your date assigned at the first scan is fixed, and then you cannot blame the date, you can blame the baby's size. You can say that the baby is not growing as well as expected, or the baby has accelerated its growth, or something like that. So you can't do that. Okay, so we touched upon it. FGR is important to diagnose because it increases perinatal mortality, it increases postnatal complications, and you can actually do something about it. So what's the point of diagnosing something if you can't help it? And you have some very strong data. In the UK, they started something which is called GAP, which is Growth Assessment Protocol. And once they implemented it in the population, the perinatal mortality declined. The number of fetal deaths declined. And this is a very significant drop. See? From about 5.26 to 4.3 something. So it is very important because you can do something about it. When you're doing FGR, it's not only ultrasound. The moment the woman walks in, the moment you have taken her, you know the clinical context, and you know that she's either at risk or she probably has a baby who is FGR. And you need to be very aware of the clinical context, the biochemical markers, which are not very popular, which are not very used this time, and of course ultrasound, which is the main focus of our talk. We will not talk about maternal risk factors because as gynecologists, I'm sure you know these better than I do. Just remember that infections are a cause of FGR. And any kind of infection can lead to that. So what are the ultrasound-based markers? You have dropping fetal growth, quartile, centiles. You have Dopplers. You have an abnormal uterine artery Doppler. You have an abnormal umbilical artery Doppler, you have an MCA which is abnormal, DV which is abnormal, ductus venosus which is abnormal. If you're really feeling very macho and gung-ho, you might try an aortic isthmus. And CPR, which is a very easy thing to derive, but probably is not used very often, is something that you need to think about. Placental anatomy, although we don't usually rely on placental anatomy to make this diagnosis, it does become important in certain conditions where the fetus might be predisposed to FGR or to other perinatal complications, and we will talk about those. And of course, reduced amniotic fluid is an independent marker of fetal unwellness. So with all of this data, we have two types of FGR. We have early FGR that happens before 32 weeks in a fetus that doesn't have congenital anomalies. It is defined as either an AC or an estimated fetal weight of less than third percentile, or an umbilical artery absent end diastolic flow, or you have an AC or EFV less than 10th percentile, which is combined with umbilical artery PI of more than 95th percentile, or a uterine artery PI of more than 95th percentile. You see, I'm not talking about absolute values here, and I'm going to demonstrate this in one of these slides. What might be normal at 26 weeks might not be normal at 32 weeks. So instead of using absolute term, PI should be less than 1.4 at every age, you should learn to correlate the values with the fetal age. And the way to do that is by using percentiles or standard deviations or Z scores or something like that. And the next type of FGR is what happens after 32 weeks. Again, this can be an estimated fetal weight of less than third percentile, or 2 out of 3 of these following conditions. Weight of less than 10th percentile, or falling fetal growth velocity, which crosses 50 percentiles during your time of examination, or a CPR, which is abnormal, which is less than the 5th percentile, or an umbilical artery PI, which is more than the 95th percentile. Late FGR is a chronic condition. The fetus might have a normal weight. The umbilical artery might have a normal value, but still those fetuses are at an increased risk of stillbirth. So we will talk about this in some detail. So an early onset FGR has a prevalence of about 1%. You have severe placental disease and you have a very dramatic umbilical artery Doppler. I mean, this is the kind of thing that you usually diagnose, that is easy to diagnose. Absent end diastolic flow, reversed end diastolic flow, that kind of thing. So this has a very high correlation with preeclampsia. It denotes severe hypoxia, systemic cardiovascular adaptation, and it has a high mortality and morbidity. And I'm sure all of you are aware of that. With late onset FGR, what might not be very obvious to you is actually more common than early onset FGR. This mild placental disease, umbilical artery Doppler can be normal. There is a low association with preeclampsia. There is mild hypoxia with cerebrovascular, cardiovascular adaptation, central cardiovascular adaptation, which means things are happening in the fetal brain. You have a lower mortality, but you have a higher incidence of stillbirth. Okay? So we need to be more sensitive to the possibility of a fetus that is normal size with normal umbilical artery, but still might have late onset FGR with diagnostic features that we will talk about. How do you do an ultrasound? Of course, you do your measurements. You do BPT, HC, AC, FL, you do your Dopplers, and if you are fortunate enough to have the lady come in twice, you can plot the profile, you can plot the growth, or you can plot how the Doppler has changed over time. I don't think I would be insulting your intelligence if I told you how to get a BPD, how to get an abdominal circumference, how to get a proper femur length, but some of you might still find this useful. And these are actually very good sections that have all of the geographical and anatomical marks that define a good section. So you have a good section for head circumference and BPD, you have a good section for abdominal circumference, and you have a good section for femur length. Growth charts. Now, I'm hoping that a lot of you are using growth charts. Okay, some of you have growth charts in your machines. Some of you might have made photocopies of growth charts, but you must remember that not all growth charts are the same. That is especially true if you are using the WHO intergrowth chart. WHO had a worldwide multi-center trial to define growth charts, and Pakistan had Aga Khan University participate in that, and they derived a growth chart, and they said that everybody, the whole world's babies follow this kind of growth. It is actually a bit of a overstatement. Ideally, you should have your own growth charts. And fortunately, Kashif and I, in 2015 and 16, we analyzed 500 patients and derived our own growth charts for South Punjab, and we published it in 2017. Interestingly, when we superimposed these growth charts on Hadlock, we found that there was complete correspondence. So if you do not have access to our growth charts, you can continue to use Hadlock if that is what you're using, and be assured that these are pretty good in our population. Okay, growth velocity. I spoke about growth velocity. How do you get growth velocity? It is better to have certain dates. You should have two scans that are at least 3 weeks apart. Some people push it to 2 weeks, but I would prefer to have 3 or 4 weeks. You should measure AC and HC. इस पे बड़ी शिकायत है मुझे. A lot of people don't measure HC, a lot of people don't measure AC. These are very, very important parameters. HC, perhaps there was somebody who was saying that perhaps we should stop measuring BPD, because BPD can be affected by so many factors that are not really representative of fetal growth. You can have a compressed head, you can have a dolichocephalic head, you can have brachycephalic head, and that will just give you a spurious BPD result, but the HC in all of these patients is going to be more accurate. So you must do an HC, you must do an AC. And AC is a pretty difficult parameter to acquire accurately, and you need a lot of practice to do that. And you must remember that even if the fetus is appropriate for age, any small drop in growth velocity is associated with an increased risk of FGR. So not only must your fetus be growing, it should be growing as well as your growth slope that you already have in your charts is predicting. So if it is dropping, it's not good. So in this case, you see the orange diamonds, this is in normal range, and this is still in normal range. If you hadn't done a growth velocity, you would not have realized that although the fetus is in normal range, the growth velocity has declined. So if you had done only one measurement here, you would have said, okay, this is still normal, it's a kind of a smallish baby, but it's okay, not too bad. But if you had the previous data, then you would realize that no, although this is normal, this has dropped, and this has dropped significantly, definitely more than 50 percentiles. And so this is definitely FGR. So that is why when an ultrasound person says, okay, please send the baby back for after a month, he's not just trying to make a fast buck. This is actually an important thing to consider, that you should be doing your growth profiles by at least 2 or even more ultrasounds. Doppler, you do an umbilical artery, MCA, you do CPI, you do ductus venosus, and you do uterine artery. How many of you have done a ductus venosus? Yeah? No? अरे यार आप तो उलमाए दीन हो ना यार, आप तो any more? Okay, a ductus venosus is very, very underutilized. It should be done in every first trimester scan, as I'm sure Fazil is going to tell you. It is a marker that has a 20% association with fetal aneuploidy, with cardiac disease, or a generally poor outcome. So when you're doing your, and actually a first trimester ductus venosus is pretty easy to do. It's much easier than a second or third trimester ductus venosus. Okay? Right. Umbilical artery Doppler, we all know that it represents placental vascularization. After 20 weeks, you should have a positive diastolic flow. The PI continues to decrease as the pregnancy advances. Decreasing PI means that the diastolic flow component starts to increase. You can use an SD ratio, but a lot of the world uses PI. Personally, I use PI. But your machines are going to give an output which has both SD ratios and PI. Just don't eyeball. Get your numbers. Okay, let's do an experiment here. Normal or abnormal? This one, at the end. Normal or abnormal? Abnormal. We all agree? Okay. Normal or abnormal? Abnormal. Good. Normal or abnormal? How many for normal and how many for abnormal? You are for normal? How many for normal first? Normal, 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 normal. Normal or abnormal? Normal. Okay? Now let us see what the reality is. See, that is the problem with having an absolute value to define your normals over the whole or over a large portion of fetal age. Now, although the value is 1.32 PI, which a lot of you would say, 1.4 se kam hai, this is normal. Actually, for this age, this value is wrong. And you see, this is the normal chart, and this value is definitely over the 95th centile. So that is the importance of not relying on absolute numbers in anything in fetal ultrasound. We should start using percentiles when we are assessing, analyzing, and reporting our fetal ultrasounds. Because a percentile is age specific, right? Ye jo percentile chart hai, you know, this is at 32 weeks, these are the values, and the values have changed by the time you come to 40 weeks. So it doesn't make sense to have one value to serve your whole gestational age. And by the way, these charts are very easily available. If you go to FMF website, these are free. You can just put in your numbers there and it will give you, ye sare FMF se liye gaye hain. Okay. When you're doing the umbilical artery Doppler, you must remember that the PI at the placental end is different than the PI at the fetal end. And sometimes this can be quite significant. For example, this is the same patient, and the PI near the fetus is 1.5, and PI near the placenta is 1.14. So that is how dramatic the difference can be. So you need to site your ultrasound gate at the right location. Now, I don't know if you know this, but there is something called Hertel's anastomosis, which connects the two umbilical arteries, you know, near the placental. Sometimes you can actually see it if you do a Doppler of that area carefully. And that equalizes the flow in both umbilical arteries. So it doesn't matter if you're using one or the other. But in about 15% of the cases, your umbilical arteries tend to be asymmetrical, and your flow tends to be asymmetrical. So in your cases where you have an abnormal umbilical artery PI, it always makes sense to look at the other umbilical artery also. For example, this is a cross section. One umbilical artery, the other umbilical artery. It is very obvious that one umbilical artery is smaller than the other umbilical artery. Same patient, you put the gate, you have a wide gate that steps on both umbilical arteries, and you have two kinds of Doppler spectra. One by one is 1.33 and 0.69. Okay, so that is how big the difference can be. So if you have a patient with an abnormal umbilical artery, you should always try and look at the other umbilical. It's not difficult at all. दोनों नजर आ रही हैं, एक पे रखा पे दूसरे पे रख लिया. Now, should you use a free loop or a paravesical? I think there's just for interest, there's a lot of debate on this, because for twins you're already using paravesical because it's difficult to differentiate what fetus a particular loop of cord belongs to. So you're already using paravesical. So it might be more useful or more reproducible if you use paravesical umbilical arteries. SUA, single umbilical artery, it can happen in up to 5% of singleton pregnancies. When this happens, obviously one umbilical artery has to carry all of the blood that usually would have been carried by two umbilical arteries, right? So this umbilical artery dilates, and since more blood is flowing, the PI drops, right? The diastolic flow increases. So if it's an SUA, your PIs might be lower than what the fetal status would actually tell you. But you must remember that SUAs are associated with smallness and FGR. So if you have an SUA, without scaring the patient, you need to explain to them that in some of the cases, your baby might be smaller and we need to monitor this more carefully. And in twins, this adaptive dilatation does not take place. Okay. The umbilical artery Doppler, please remember, is not a very sensitive parameter for placental dysfunction. Actually, about 30% of placental villi need to be lost before your end diastolic flow will reduce. And about 60% of your villi will need to be lost before your end diastolic flow will become absent. And if you have an absent end diastolic flow, this can persist for several days, and it is not a calamity in most cases, and just tells you that you need to be more careful in monitoring the patient. We will talk about what real calamities are. And you must remember that, like we have already discussed, umbilical artery Doppler can be normal in early stages of FGR, and umbilical artery can be abnormal in non-FGR cases, for example, in triploidy or trisomies. Okay. MCA. How many of you do MCA regularly? How many of you do MCA regularly? Okay, there's some evidence to do an MCA regularly. We're going to talk about that at the end of this lecture. So it basically represents cerebral circulation and the response to hypoxemia. Brain is a critical organ. What are the other critical organs that the baby would like to preserve blood flow to? Adrenals, and of course the heart itself via the coronary arteries. So the baby tries to maintain the blood flow to these vital organs at the expense of other slightly less vital organs. Brain is one of them. It's easily accessible. It tells you when there has been redistribution of blood flow with preferential flow to the brain. Okay, a trick about MCA Doppler, don't press too hard. If you press too hard on the fetal head, well, sometimes you have to because your patient is very large. If you press too hard on the fetal head, your diastolic flow goes down. And this is a demonstration of the same patient with pressure on the right and without pressure on the left. So you need to be careful about how strongly you're pressing on the fetal head. Now this brings us to cerebroplacental ratio. Okay, this is the ratio of the PI of the MCA to the PI of the umbilical artery. No rocket science here. आपने umbilical artery कर ली, आपने MCA कर ली, PI कर ली. Most machines might calculate it for you automatically and save you the trouble. Otherwise, just take out your calculator, put your MCA PI on the top, your umbilical artery PI on the bottom, hit equal to, and you'll get the MCA, right? Normally, the MCA PI is always more than the PI of the umbilical artery. So your CPR should be normally, it is normally more than 1.0. If it is less than 1.0, then it means that there's something wrong with the baby, and there is redistribution of blood flow, and there is fetal adaptation to hypoxemia, and that is not a good sign. And this is especially important because, like we have already said, that umbilical artery flow can be normal in these babies. Even MCA flow can appear to be normal in these babies. They can both be in normal range, but when you derive the CPR, that turns out to be abnormal, and that should bring alarm bells in your head. Again, CPI, you can use your calculator, or you can just go to the FMF website and you can put in your numbers, and you get these beautiful charts that you can print out and give to the patient as a record of what the calculation was. Ductus venosus. Okay, this is something that we are probably not using as much. We should be, especially in first trimester scans, and I'm sure Fazil Sabhe is going to talk about that. It is the strongest single Doppler parameter that predicts the short-term risk of fetal death in early onset FGR. So if you have an abnormal ductus venosus flow, it means that fetal demise is imminent in most cases. And you need to bring that fetus out and try to resuscitate that fetus ex utero. It has a typical waveform. You have three positive waves, two bigger ones and one smaller one. And the smallest wave is the A wave, and that is what we are interested in. If it becomes zero, but some people say that if it becomes negative, that is a poor sign of fetal health, and depending on at what time you have acquired it, it can tell you different things. In the first trimester, abnormal spectra can be found in aneuploidy, like I said, in cardiac disease, and just general adverse pregnancy outcome. And in the late second trimester or the third trimester, like I said, it tells you that the baby is very, very ill and demise is imminent. It's an absolute indication for delivery, even if the baby is 26 weeks. It's just at the age where it just becomes viable. You need to take it out. Okay, so these are two abnormal ductus venosus Dopplers, and you can see that there's a negative A wave here, there's a negative A wave there. The important thing is that in cases of negative A wave, there should be nothing above the baseline. And if you're not sure, you can just speed it up and widen your spectra And that will make it clear if your baseline, above the baseline area is clean or not. And another thing, you need to really narrow your window, especially in the first trimester. You need to have the narrowest possible window, 5.5 millimeters, or maybe even less than that, if possible. Uterine artery Doppler reflects trophoblastic invasion. This can be inadequate. This can lead to starvation of the uterus. The uterus responds by throwing out bioactive markers, and the mother responds by going into preeclampsia and FGR. And so if you can do it, if you can predict early, you can do something about it. Especially you can start aspirin. And in fact, the aspirin trial, which is quite old now, effectively demonstrated the usefulness of aspirin when started early. So this should be started before 13 weeks. And so that is the time when you should be doing a uterine artery Doppler in all of your patients, so that you can intervene and do something about the onset of preeclampsia. Okay. In the first trimester, you use a TVS. In the second and third trimesters, use transabdominal. And stop worrying about notching. You know, everybody says dicrotic notching, dicrotic notching. Well, dicrotic notching is very normal in a considerable number of fetuses, depending upon the age at which you have scanned them. So don't worry about dicrotic notching, but worry about PIs, worry about percentiles of the PI. Okay, again, use age-specific charts. Again, my favorite website, fmf.org. It has a page which gives you the uterine artery PI. And in fact, I prefer it over what is in my machine, because I think that my machine kind of over-reports the significance of PIs according to age. So age-specific charts, more than 95th percentile is bad. You should do a uterine artery Doppler for everybody in the first trimester, but not everybody in the second or third trimesters. You need to do follow-up in those in whom you have an abnormal result in the first trimester. I'm assuming that if everybody in the first trimester gets a uterine artery Doppler. Okay, should you be doing Doppler in everybody, or should you be doing Doppler selectively? And should you be doing umbilical artery and MCA in pre-viable stage? The answer to both of these is probably yes. If you do a Doppler early, before 25 weeks, the baby is pre-viable, it's not viable as yet. You can at least identify a population that is likely to be more affected by problems later on. So it can alert you to a closer follow-up. And if you do a third trimester CPR, you decrease the morbidity. And there is some very strong evidence about that, and we are going to talk about it in my last slides. So, late FGR. What happens to the fetus? It is the same fetus, but what happens to the fetus? Why does umbilical artery Doppler become less relevant in a fetus that is beyond 32 weeks? Now, the fetal metabolism changes and the fetal requirements change. And so, after about 32 weeks, instead of the fetus wanting to have a lot of glucose, a lot of nutrients, the fetus wants to have a lot of oxygen, right? So, the green line is the nutrients, the red line is the oxygen, and you can see that while this flattens slightly, this really goes up very rapidly. And so the fetus is more sensitive to oxygen deprivation than nutrient deprivation. Nutrition is reflected by umbilical artery, oxygenation is reflected by MCA. So that is why MCAs are more important in the third trimester than umbilical artery. Not alone, but you need to combine. So let's go back. Late FGR, more prevalent, mild placental disease. Umbilical artery is usually normal. MCA can be abnormal, but CPR is abnormal. You see, umbilical artery can be normal, MCA can be normal, but when you combine them, you get the CPR that tends to be more abnormal. In fact, some people are doing a reverse, a PCR, and they think that is more sensitive, but it has not become part of the routine practice as yet. But there is a lot of interest in putting the placental artery PI at the top and the MCA PI at the bottom. Okay, late IUGR, your CPR becomes abnormal, like in this case, and you have this really low CPR. So, don't stop at fetal weight, don't stop at fetal Doppler. Look at the fetal amniotic fluid index. You must remember that in third trimester, AFI might not truly represent the status, and you should start looking at maximum vertical pockets. And if you have one maximum vertical pocket of more than 2 centimeters, which is at least 1 centimeter wide, then perhaps your fetus is not doing too badly. Okay? And even if your AFI is less than 10, which is still within normal limits, these fetuses tend to have somewhat increased complication rates. So your AFI needs to be good. If your AFI is scanty, you should become scared. Something might be going wrong. Placenta, well, usually we don't look at the placenta. We don't give it too much importance when we are diagnosing PCR. But there can be some abnormal placental morphology. You have a very thin or a very thick placenta. You can have multiple echogenic or cystic lesions or a jelly-like appearance, or you have a marginal cord insertion which is within 2 centimeters of the edge of the placenta, or you have a high grade of placental maturity at a low fetal age. So these are all markers that all is not well. So grading of placenta is very subjective, but everybody knows what a grade 3 placenta looks like. Right? So you have cotyledons, you have an echogenicity that is surrounding the cotyledons, you have a cystic area in the center, and so this is a grade 3 placenta. If this happens below 36 weeks, it means that the fetus is struggling with some adversity. Right? The fetus might still be normal, might have normal liquor, might have normal Dopplers, might have normal weights, but an early placental maturity can be a sign of enhanced follow-up. For example, in this patient that is just 18 weeks, and you can see that's already grade 3 placental maturity. So there is definitely abnormal. So we've got all of these data, huge trove of data with us. How are we going to use it? How are we going to use it? The whole idea of getting a data is to respond to it somehow, to make things better for the fetus, to improve your outcomes. Before we go into that, just a review of the different Doppler parameters and the time to delivery. It's a complicated kind of a chart, but just look at the last line. Look at the last line. A negative A wave in the ductus venosus. It gives you only about 24 hours on an average before fetal demise. So if you find this in a baby, you need to really hurry up and talk to the patient and start managing it as a very serious case. Since 2014, and perhaps even earlier, there are several schemes that tell you how to use this data. There's one by FIGO, but the one that I use is by the Barcelona group, published in 2014, and it tells you what to do when you have a set of findings. For example, if you just have smallness and you just have just mild placental insufficiency, just low EDF in there, and mildly abnormal CPR, uterine artery, everything is abnormal, but really not grossly abnormal. You should do weekly monitoring and deliver at 37 weeks. Take it up to 37 weeks. If you have an absent end diastolic flow or a reverse flow in the aortic isthmus, you follow up bi-weekly and you deliver at 34 weeks with C-section. If you have reversed end diastolic flow in the umbilical artery and the ductus venosus PI is more than 95th percentile, you monitor daily and you deliver at 30 weeks. If it's already 30 weeks, you deliver. If it's less than 30 weeks, you monitor daily until 30 weeks and then deliver. And if you have a reversed ductus venosus A wave, you deliver immediately, even at 26 weeks. I was telling you about the usefulness of doing CPR in third trimester in everybody, right? So this is an article from last year in Lancet, and these are the results of a very long ratio 37 trial in which they determined that doing a CPR in every patient, even those patients who are growing normally, it helps with reducing the morbidity of the fetus. And what you do is you deliver these at 37 weeks. So it's a good article. If you want, I can send you a copy. Okay, so recap. If you have a small fetus, the possibilities are that you have wrong dates. These fetuses would be structurally normal. All parameters will be small. AFI will be normal. Movement will be good. Doppler will be normal. You will have normal growth velocity. You remember those blue dots? So that was a normal growth velocity that was happening at -2 standard deviation. So that was a case of SGA or wrong dates. And you do a transcerebellar diameter. How many of you do transcerebellar diameters? One. Ulmaydeen. A transcerebellar diameter is a very important parameter. We should actually try to do it in every patient because it can be tricky to get the right one, and there is a learning curve. The importance of transcerebellar diameter is that it is relatively immune to blood flow. And so while everything else in a starving baby will become smaller, your TCD might still be normal. So it is very important. But again, in third trimester, because you have so much ossification of your skull, it might be difficult to get. So SGA, so same thing. But in SGA, you should look at the parents. If the mother is 4'11", 4'10", the father is, and height, fetal size derives from mother's genes rather than father. So mother's genes are more important in deciding fetal size. So if the mother is short, then you're probably looking at, you might be looking at just an SGA. In a starving small baby, which is our typical FGR, you are structurally small. You have asymmetric parameters. The head size would be, this is what we call, slide. You call asymmetric FGR. You have bad Doppler, and you have an abnormal growth velocity. See, you do it 3 weeks, at least 2 weeks, and don't do it weekly. You won't be able to make any sense of the numbers that you get. If you have an abnormal small baby, that is the baby that is afflicted with aneuploidy or with infection, you will have structurally abnormal baby. You might have a cardiac problem, or you might have abnormal calcification. You have a small AC compared to the head circumference. You have a small thorax. AFI might be decreased. Doppler might be normal or abnormal, but you have an abnormal growth velocity. So basically what you're trying to do when you have small babies is that you're trying to balance the risk of prematurity with the risk of stillbirth. And that is the last slide. Thank you very much for your patience. If you have any questions, I would be happy to answer. If not, I will just have that glass of water that was offered to me and rest my feet. Yes, sir. Please, जरा ऊंचा बोलिए. करीब आ जाइए. हाँ जी, आ जाइए. जी, बहुत वाइड रेंज होती.
कि लोग कह रहे होते हैं कि ये पानी रिड्यूस्ड है और वो AFI 10 है, 10 सेंटीमीटर है, 12 सेंटीमीटर है. कोई ऐसा पैरामीटर हो सर जिसमें हम डिसाइड कर सकें कि ये पेशेंट के लिए एब्सोल्यूट इंडिकेशन है फॉर प्री टर्म डिलीवरी?
एब्सोल्यूट इंडिकेटर तो रिलेटिव इंडिकेटर है. AFI इंडिपेंडेंट इंडिकेटर है ऑफ फीटल अनहेल्दीनेस. AFI में एक और चीज़ बहुत इम्पॉर्टेंट है कि आप AFI you do it at the end of your examination, but when the baby lies down, the amniotic fluid redistributes, and you might pick up larger pockets at the end of your scan than you would at the beginning of the scan. And you said there is a very wide range. Yes, indeed, there is a very wide range. Even for AFI, you have percentiles, and you can use that to tell you where your AFI values are. And if your AFI is low, you'd probably move to maximum vertical pocket instead of AFI, because in late pregnancies and in low AFI volumes, AFI MVP tends to give you better results than AFI. जी जी हाँ
जीपीज ने किए होते हैं अल्ट्रासाउंड्स, तो उनके पास भी तो उसकी ईडीडी आ रही होती है एट 14 वीक्स एंड 20 वीक्स, बट यूजुअली वो उस पर नहीं लिखते. तो जब हम गायनाकोलॉजिस्टों के पास वो पहुंचते हैं तो उन पर ईडीडी नहीं होती लिखी हुई, और उसके लिए बड़ा प्रॉब्लम होता है. और सर एक और भी होता है कि ऑक्सीपिटो पोस्टीरियर एंड एंटीरियर, उसकी बहुत सिग्निफिकेंस है फुल टर्म के ऊपर डिलीवरी के टाइम पर. तो आई शुड से कि सबको उस पर लिखनी चाहिए कि बेबी की पोजीशन एंड फ्लेक्शन और एक्सटेंशन एट द नेक. तो ये तो बहुत एक्सपर्टीज इसके लिए नहीं चाहिए, तो अगर वो लिख के दे देंगे तो उनको उसके लिए आसानी हो जाती है.
मेरे ख्याल में आपकी पहली बात तो बिल्कुल दुरुस्त है कि अगर उसके पास डेटा नहीं है, रिलायबल डेटा नहीं है, तो आपके लिए दुश्वारी हो जाती है उसको मैनेज करने में. मे बी साइज इज नॉट समथिंग दैट यू हैव, बट you still have Dopplers, you still have CPR, you can use that, you still have Liker. Occipito anterior or posterior, if you ask for it, I'm sure people will do it. For example, there are gynecologists who always ask for cord around the neck. I don't know why, but they do, and I make it a point to give this information to them. So if you start asking for if this occipito anterior or posterior, your whoever is doing your ultrasound will definitely give you this information.
Excuse me, sir.
जी सर.
मैं इस क्वेश्चन का आंसर करना चाह रहा हूँ. ये जो पोजीशन ऑफ द ऑक्सीपुट पे बात हुई अभी, पोजीशन ऑफ ऑक्सीपुट एंटीरियर और पोस्टीरियर ऑन अल्ट्रासाउंड हैज़ नो सिग्निफिकेंस. ये जो पोजीशन है दैट इज़ ड्यूरिंग द लेबर रोटेशन होती है, सो दैट इज़ इम्पॉर्टेंट ड्यूरिंग व्हेन वी आर मॉनिटरिंग द लेबर. So it is not important to mention whether it is occiput anterior or posterior.
Okay, yeah, actually you're right, but there is something which is called ultrasound during labor, and people are using ultrasound to monitor the progress of labor. So you're right that perhaps if we do an ultrasound at 36 weeks or 37 weeks, what we find then might not hold true when labor starts. You're definitely right. But I'm just saying that if somebody asks for a specific information, as service providers to physicians, we are bound to give that.
Sir, my question is, You have told the paramount importance of ductus venosus. Would you like to tell me any tip for localizing the ductus venosus in the first trimester?
Practice.
Any tips, sir?
या डक्टस फिनोसिस के लिए एक्चुअली आप डक्टस फिनोसिस की सर्टिफिकेशन भी कर सकते हैं. एफएमएफ की वेबसाइट के ऊपर वो आपको सिखाते हैं कैसे लेना चाहिए, और आप उनको 3 इमेजेस भेजते हैं तो वो आपको सर्टिफाई भी करते हैं, जो हर साल आपको रिन्यू करना पड़ता है. एनीवे, डक्टस फिनोसिस फर्स्ट ट्राइमेस्टर में यू नीड टू हैव द फीटस फेस एंटीरियरली. The fetus should not be moving a lot. You need to zoom so that the fetus thorax and abdomen occupy most of your screen. You need to turn on your Doppler so that you can see the ductus venosus. You need to have an angle as close to 0 as possible, which means that your fetus should be either head side down or standing or lying in a Trendelenburg's position, so that your geometry of the ductus venosus and your ultrasound probe is as close to 0 as possible. And then you turn on your Doppler, and you must remember that ductus venosus is the area with the fastest velocity in that system. So this is the area that always shows elysing. So you put your Doppler gauge there at the area of elysing, and you must remember that you need to reduce your Doppler gate to as small as possible, because umbilical veins are right there, hepatic veins are right there, and they can contaminate your ductus venosus Doppler. And जो hepatic veins का जो spectrum है, that is right near the baseline. So so it can completely confuse you and make you come to an erroneous diagnosis if you have contamination, if you're not able to recognize contamination from the hepatic veins. Okay? Thank you very much. अच्छा,